Today we are looking at the case study of Patrick, who is a 78-year-old male who has worsening of his left-sided heart failure and chronic obstructive pulmonary disease. Patrick is very tired and coughs regularly, and he suffers from dyspnea. His legs are swollen from the knee down and he walks slowly. His current observations and body size measurements are blood pressure 135/85, heart rate of 155 beats per minute, weight 95 kilos, height 180 centimeters, waist circumference 104 centimeters. His previous medical history indicates that he smoked from age 20 to 60, quitting smoking in his early 60s. He has also had a myocardial infarction to a branch of his left coronary artery at the age of 68. There are several fasting blood test results that we will also discuss throughout the presentation. One of the key disease factors that is contributing to Patrick's respiratory symptoms is his considerable history of smoking, which is likely to have caused his COPD lung disease and permanent damage to his airways. The fact that Patrick stopped smoking 18 years ago is still suffering symptoms suggests that he caused permanent irreversible damage to the cells that line his airways. Normally, ciliated pseudostratified columnar epithelium cells line the airway to help trap and disperse pathogens. Smoking paralyzes the epithelium cells and then they undergo metaplasia and become stratified squamous epithelium to provide protective qualities against the irritant. This structural change in the cell also changes the function of the cell. The inflammation of the bronchi from the long-term exposure to cigarette smoke produces excess mucus. Because the cells no longer have functioning cilia, it means that the mucus and the pollutants are not being removed and therefore mucus starts to accumulate and block the airways. This explains his chronic cough due to excess sputum production and difficulty in breathing due to the mucus blocking his airways. One of the backwards effects of left-sided heart failure is the development of pulmonary edema. COPD can also lead to pulmonary edema. Due to Patrick experiencing left-sided heart failure, also known as congestive heart failure, blood is not moving out of the left ventricle fast enough, causing a buildup of fluid in the alveoli within the lungs, resulting in a ventilation-perfusion mismatching. This is known as pulmonary edema, which presents symptoms such as irregular coughs, dyspnea, fatigue, and a low tolerance for physical activity. Pulmonary edema is when the respiratory membrane is thickened with fluid and gas exchange is reduced, thus exhibiting the above symptoms. This directly affects the systemic circulation in that it is not receiving sufficient blood flow. The RAS system, or renin-angiotensin-aldosterone system, is activated with the aim of increasing blood volume and blood pressure. Patrick's symptom of peripheral edema is swelling of the legs can also be explained by this process. The average heart rate in adults is approximately 75 beats per minute. Patrick is presented with a heart rate of more than double that at 155. Patrick's history of myocardial infarction would have caused cell death or necrosis in the myocardium cells. The cell death causes permanent loss of function in the affected area, including ventricular hypertrophy and reduced contractility. Baroreceptors detect a change in arterial pressure and forward this information onto the medulla. Reduced cardiac output triggers the cardioacceleratory response through the activation of the sympathetic nervous system and the RAS system to detect heart rate through vasoconstriction by releasing adrenaline or noradrenaline to bind to B receptors to stimulate vasodilation. This could explain Patrick's tachycardia. Increased levels of potassium and decreased levels of calcium are two factors that enact the cardioacceleratory response initiated by the sympathetic nervous system from the medulla. Patrick's medical history outlines that he suffered from a myocardial infarction. This is most likely to have caused his left-sided heart failure. Patrick's high LDL levels and low HDL levels and high triglyceride levels indicate dyslipidemia, meaning that he has most likely developed atherosclerosis causing an abnormal deposit of lipids in his blood vessels. This fat deposit that might be partially blocking the blood vessel, together with stress, exercise, or the development of a thrombus, can lead to a more severe blockage causing a myocardial infarction. This leads to ischemia and hypoxia, which means that the cells are unable to produce enough ATP. or energy. After 20 minutes of hypoxia, irreversible injury and necrosis occurs. This cell death causes permanent loss of function in the affected region, including reduced contractility. This decreased cardiac output because of reduced contractility leads to heart failure, as the heart is still beating but cannot meet the oxygen needs of the tissues in the body. The reduced cardiac output triggers adaptive mechanisms including ventricular remodeling in the form of hypertrophy and dilation, and activation of the RAS system to try and restore homeostasis. However, these adaptive mechanisms actually further the progression of the heart failure instead of repairing it. As mentioned previously, Patrick's past history of smoking is the most likely cause of his COPD. COPD is an obstruction of the airways characterized by progressive irreversible damage to the respiratory membrane. The damage causes excess mucus to build up and the inability to clear pathogens because of damage to the cell epithelium. The obstruction causes reduced ventilation and leads to hypoxemia or low oxygen in the blood, and hypocapnia, high levels of carbon dioxide in the blood. Because blood cannot be reoxygenated effectively at the site of gas exchange in the alveoli. It's likely that Patrick's COPD has contributed to the worsening of his left-sided heart failure. The blood flowing through Patrick's pulmonary circulation is not being oxygenated properly. This means that there's an increased demand for oxygen that the heart is struggling to keep up with. This would worsen Patrick's left-sided heart failure as cardiac output continues to be reduced. Patrick is now at high risk of developing right-sided heart failure. Both chronic obstructive pulmonary disease and left-sided heart failure can both separately lead to right-sided heart failure, which can be explained here. Right-sided heart failure can result from left-sided heart failure because of the increase in afterload and preload, yet decreased contractility of the right ventricle. This means that there's an increase in blood accumulation in the systemic circulation and insufficient blood flow through the pulmonary circulation. Patrick's COPD can also lead to the right-sided heart failure due to pulmonary hypertension. The pulmonary arterioles and capillaries in the lungs can be damaged and blocked by COPD, which increases the blood pressure through these blood vessels. This makes it harder for the right ventricle to pump blood through the pulmonary circulation, leading to hypertrophy and ventricular remodeling. As discussed previously, Patrick's left-sided heart failure means that he has insufficient cardiac output, which triggers adaptive mechanisms in the body to try and overcome this. One of these mechanisms is the activation of the renin-angiotensin-aldosterone system, or RAS. This is due to a reprioritization of blood flow to the most important organs, the heart, brain, and lungs. This means the kidneys become a lower priority and receive low renal blood flow, which activates the RAS system to retain fluid, including water and sodium. This explains Patrick's hypernatremia. Sodium plays an essential role in neuron and muscle function, and as a result of hypernatremia, can lead to alterations in brain function. Patrick's test results also show that he has hyperkalemia, hypocalcemia, dyslipidemia, and anemia, which can be attributed to the progression towards chronic kidney disease as mentioned earlier on. Hyperkalemia can also disrupt neuron and heart function. Chronic kidney disease also presents neurological symptoms such as, but not limited to, drowsiness, sleep disorders, impaired concentration and/or judgment. As the disease progresses to the end stage, it can lead to seizures and coma. Patrick's blood test results show that his fasting plasma glucose level was high at 8.5 millimoles per litre, where a normal level should be less than 6.1. This should be investigated further to determine if Patrick has developed type 2 diabetes mellitus, as that is further supported by his higher than normal waist measurement at 104 centimetres. Patrick should undergo an oral glucose tolerance test to monitor his blood glucose 2 hours after having a glucose drink. In a non-diabetic person, the results would show a spike in glucose immediately after drinking the glucose drink that would then return to normal within 2 hours. In a diabetic person, the blood glucose level will remain high, most likely above 11.1 millimoles per litre after the 2 hours. In Patrick's case, we would expect the result to be abnormally high to confirm that he does have diabetes mellitus.